go on to our next speaker, Dr. RASHMI Murthy, who is a consultant ophthalmologist from L.V. Prasad Eye Institute at Hyderabad. And she is going to be talking on bleb-related infections and endophthalmitis. On to you, Dr. RASHMI.
Good evening, everyone. At the outset, I would like to wish Happy Sankranti to all.
That was the best thing you did. I should have done that before.
And Dr. Chitra for giving me this opportunity. So, we all know that trabaclectomy is a conventional filtration surgery that we've all used, and there are so many, all the topics have been covered about this. So we basically create a conjunctival opening and a scleral flap opening. And most of the times it does work well, and our results are good, around 80 to 85% success rate in primary glaucomas, and they do relatively well in secondary glaucomas too. So the problem occurs in few eyes when we see these complications. Sometimes they are mild, sometimes they're very serious. And the most rare but very serious is this, which is bleb-related infection and endophthalmitis. Coming to my case, he was a 16-year-old boy who was referred to our Institute for IOP Control. He complained of gradual diminution of vision in both eyes since 3 years. He was already on 2 medication with oral Diamox. Systemically and other history were not contributory. His visual acuity in both eyes was 20, 30, and 10, which was getting corrected with -2 dioptrosphere. Anterior chamber, both eyes had shallow anterior chamber, clear lens with minimal phacodonosis. Gonio showed occludable angles with more than 2-angle goniosyneche and RAPD in the right eye. Cupping was advanced in both eyes with high intraocular pressures in both eyes. So the first thing that comes to our mind when a patient with young age myopia and angle closure glaucoma is spherophakia. Because lens was not small in size, we only say it as spherophakia and not microspherophakia, but there was associated angle closure glaucoma. We did laser peripheral iridotomy in both eyes with and added medication, but in spite of that, the pressures were not under control. So we went ahead and did limbal-based trabaclectomy with mitomycin C under GA. And primary anterior chamber reformation is something that we do as a routine in spherophakia eyes. And in the right eye first, and then followed by the left eye with a gap of 3 weeks. Right eye was uneventful and the IOP was well under control. When we come to the left eye surgery, on day 1, the pressures were very low with a diffuse overfiltering bleb, very shallow AC with a lenticulocorneal touch. So because of that, it did not improve the next day also. So we went ahead and did an AC deformation, but because the AC was not forming even with air, we opened the bleb area and put extra sutures to decrease the filtration, and we additionally put some glue to decrease the filtration. But 2 days later, the patient presented with severe pain in the eye, hand movement vision, lid edema, discharge, and conjunctiva was markedly injected. So if you see that there was a lot of discharge in the eyes and the conjunctiva was congested, and the area of the bleb, this is intraoperative photograph. So the area under the bleb was showing a yellowish hue. So the discharge which was there at the lid was taken and it was sent for microbiological examination. And then first we could see that there was some pus at the area of the conjunctival wound. The sutures were cut, the 80 vicryl was cut. And then we saw that once the conjunctiva was opened, there was copious mucopurulent material that came out of the area, which was aspirated and sent for microbiological examination. Surprisingly, we saw that the conjunctival edges and the underlying sclera was not necrotic, that was healthy. We put additional sutures to decrease the filtration because we did not want any communication between the bleb area and the eye. So, in fact, the eye was quiet and there was no pus in the antechamber, or the fundus was also, the view was good. So, it was just a localized bleb infection. We put a scleral patch graft and then close the conjunctiva with interrupted sutures. Because we had totally closed the filtration, we did not want to put this suture as a watertight suture, because if there was any additional pus that could drain through this openings that was there. So we did not put a watertight suture. So then the gram staining revealed gram-positive coca and the culture revealed Staph aureus. which was susceptible to cefazolin. So initial 5 days we gave intravenous antibiotics and then continued topical fortified cefazolin for 1 month. This was the appearance at 1 week, where the bleb area was healing and the AC was still shallow, but there was no evidence of any infection. At 1 month, the AC had improved. This was at 2 months, the bleb had totally scarred, but the IOP was under control. So I suppose there was some filtration occurring in that area, but there was no evidence of any infection. The patient had developed anterior subcapsular cataract through this course. This is another patient where in the area of the releasable suture, there was corneal suture infiltrate. So basically, it was sensitive to cefazolin and we treated with cefazolin. So to summarize, bleb-related infections are less common without the use of MMC, which is 0.2 to 0.5%. But with the advent of MMC, the incidence has increased, with the risk factors being young age, fornix-based incision, bleb leaks, thin neovascular cystic overhanging bleb, use of releasable sutures, and diabetes. Early blebitis less than 1 month, most commonly caused by Staph aureus, which is similar to acute post-op endophthalmitis and usually occurs after 1 week. Basically, we treat with systemic and topical antibiotics empirically and then based on the susceptibility. If it is endophthalmitis, it is more severe and sight-threatening, pars plana vitrectomy and intraocular antibiotic. And then based on the susceptibility we treat. The visual outcome is poor with virulent bacteria like Streptococcus and Coagulase positive, but the benign course with Coagulase negative staph. So the pearl is that if it's a high myope, young age, shallow AC, it's a spherophakia just for the postgraduates.
Then 1 minute remaining.
Bleb-related infections are rare, but they are sight-threatening following trabeclectomy. Timely management is very important based on whether it is localized or endophthalmitis. Localized blebitis have better prognosis, and endophthalmitis is vision-threatening. And risks and benefits of mitomycin C augmented trabeclectomies should be taken into consideration. Thank you.
Thank you very much. Just one question to you before we go on to our next speaker, a very simple question. You've told us how you would treat a blebitis without vitreous involvement, but do you think even if you have managed it early, there are chances of the success rate of the bleb functioning is a possibility at all?
Early bleb infections, like only blebitis, they do work. So personally, this is the only patient that I've seen when I was a fellow and I've been doing my traps, but it is very, very rare condition. So endophthalmitis, I think, does not have a very good visual potential, but just blebitis and bleb abscess, they do have good potential. But this patient did well even after we closed the trabeclectomy site. In spite of that, the pressures were under control. So we do suppose that there was some filtration that was going on, and he did very well after that.
Dr. Vinay, you have, Rangya, have anything to add?
No, I think that, if the bleb continues to function and the pressure continues to remain in control, then I think we should just, thank that that's how it is actually. So, but I think she was very fortunate that, it really didn't get into the vitreous. There was so much pus that one would have anticipated that little bit trickle into the vitreous spine. But I think she was extremely blessed actually not to have faced that.
One question to Dr. Rashmi. See, many times we see very thin-walled bleb post mitomycin C surgery. So we are scared whether to touch or intervene because it is working fine. But there is always a potential for infection if it's a person coming from a far-fetched village or somewhere. So do you really need to intervene? That is one. Second is the early bleb infection. Like the source can be just like a cataract, touching eyes, or the swimming, or any cosmetics. So what all could be the causes that you found during the early blebitis and compared with the other aspect?
Yeah, for the first question, I feel if the bleb is very thin and cystic, but there is no hypotonia or there is no bleb sweating that we say, then I think we can just leave it because there is an epithelium which is covering it. But if there is a bleb sweating, that means if when we stain, there'll be some areas of pinpoint leaks that happen, then I think we should go ahead and repair such blebs to prevent future infections. We have published a case series on that too. The second one, early bleb infections, is just like our cataract surgery infections. Like if there is any issue with the hygiene, or if there is an issue with the instruments that we use or the fluids that we use. So we were actually suspecting that the fibrin glue that we used might be a source for the infection, but we did not find any evidence for it. But it is not very common to have early bleb infections. One report I read on releasable suture causing as a suture tract causing the bleb infection. But most commonly are late infections that have been reported.
Thank you.